Well, good afternoon. My name is Jeff Stauffer, Community Relations Director with Elville and Associates, and welcome to our webinar today, the 8th in the Elville webinar series, Wellness Series, Part 2 of After the Dementia Diagnosis. So how this will work today, if you're new to our webinars, if you are, welcome. We're glad you're here. And if you're a frequent attendee, we thank you as always for your support of our webinar series. So you as the attendee are in listen-only mode. However, we're going to continue to try something a bit different today as we want this to be as interactive as possible. We are going to unmute all attendees at various times during the presentation when Ellen and Michelle are looking for your feedback and thoughts, which will be frequently. So while you can still pose your feedback through the questions panel and chat feature, feel free to speak up and let your voice be heard throughout the presentation. Also, you received the presentation slides by me yesterday through email. For your convenience, to take notes on it if you wish. If for some reason you did not receive that email, the handout is currently located in the section marked Handouts in the right-hand portion of your screen to download at this time. Everyone will also receive a post-webinar feedback email right after the presentation, and we do ask that you please just take a couple minutes to fill out this very simple survey, offer us your thoughts about today's presentation. Elville & Associates works with families and clients every day with the ideals of client education, collaboration, and compassion in mind. And we're always available for consultations to discuss your family's planning needs. So contact me at any time if we can be of any help to you. And we're always available to be a resource to you in any way, now and in the future. So at this time, as we have a lot to cover, I would like to welcome back and turn the webinar over to our presenters, Ms. Ellen Platt of the Option Group and Dr. Michelle Fritsch of Retirement Wellness Strategies, who will share a bit about themselves and get started with the presentation. So Ellen and Michelle, it is all yours.
Thank you, Jeff. Good afternoon, everybody. I'm Ellen Platt with the Option Group. We are a company that provides private case management and advocacy services. And in a large part of the work that we do is working with families who are dealing with dementia. So we're going to be starting, this is actually a part 2 of what we started last month because we had so many great questions and so much content to cover that we decided instead of rushing through it, we would spread it out amongst 2 different webinars. So this is the second. We're going to be a quick overview or refresher of what we did last month for those that were here, or just bring you up to speed if you weren't able to join us last time. But I'm going to let Michelle introduce herself before we get started.
Thank you. So I'm Michelle Fritsch. I'm a clinical pharmacist. I'm the founder of Retirement Wellness Strategies. So my focus is on the prevention side, helping people with a strategic plan for their personal health through retirement and beyond. But as a geriatric specialist, I have guided so many families through the process of dementia and especially making medication-related decisions. So that will be my emphasis and my part of today's program. And please, as Jeff indicated, ask your questions. This is most importantly about you and making sure you get the information that is most helpful to you. So welcome.
So just a quick overview. There's a lot of terms that you hear and sometimes it's really hard to understand, and people hear Alzheimer's and they hear dementia and they hear vascular dementia and all these different terms, and it's kind of hard to understand. So if you can think of dementia being that umbrella term, so that is the overlying diagnosis, but there are a lot of different versions. In fact, there's probably close to about 200 different versions of dementia. So Alzheimer's is the most common, about 50 to 75% of cases are Alzheimer's. Some of the more popular ones that you would see are more common ones, in addition to Alzheimer's, are the vascular dementia, which has to do with the vascular workings in the brain, Lewy body, frontotemporal dementia, pressure hydrocephalus, and there's mixed dementia, so it might be a couple of these kind of combined. But these are the most common, but just think of dementia being an umbrella term And there's lots of other forms of dementia, and it just really depends on the etiology, how it started. Was it a brain accident, a head injury? Was it from drinking? Was it from plaques and tangles in the brain? So there's lots of different ways you can get dementia, and sometimes the treatment is different. But we just want to kind of help people understand what the different aspects are of dementia. So the early signs really are when people start experiencing memory problems, forgetting events. And this is not just like forgetting your keys and then finding them or retracing your steps, but it really is when it becomes problematic, when it makes it hard to, difficult to function and starts getting in the way of your daily activities. Some people may have actually started on the path of cognitive impairment perhaps 10 years before they actually receive a diagnosis. So this is kind of a long-term thing where you might start seeing these signs, but when they become more frequent, or you're not able to retrace your steps, or you're forgetting things that you used to do every day, like how to get to the grocery store that's a block away, things like that. That's when you start thinking, well, that might be some early signs. Might see some personality changes, some mood changes, trouble focusing, getting a little bit confused about things, again, that things you weren't confused about before. Sometimes that'll lead to depression, somebody feeling a little despondent about just not being able to function at the level they used to function. And then they might start losing the ability to do everyday tasks like writing a check or managing medications or doing things like that. So those are kind of the early red flags that we might see. And we want to kind of point out that everybody's progression is different. It could be a slow, gradual progression. It could be, a little bit quicker. People who get dementia at an early age, when it's called not early signs, but early onset dementia, sometimes people in their 40s, even sometimes as young as their 30s, can be diagnosed with dementia. And that usually is a very, very fast progression. So everybody kind of has a different progression. It affects different areas of the brain. So somebody may have difficulty with visual spatial kinds of things. Another person may have difficulty with expressing, communication and expressing their words or understanding words. So it just depends on what area of the brain is affected. So when we start,
I apologize, Ellen.
Go ahead. You want to add something, Michelle?
Oh, I said I fell behind on advancing the slides. I apologize.
Oh, sure. So getting to the middle stage then, that is when people start having difficulty with really comprehending language. And it might be spoken language, written language. It may be trouble communicating expressively or receptively. And we start withdrawing from social situations, feeling that a little uncomfortable because we realize we're not functioning at the level that we used to. Maybe we're a little bit embarrassed and we don't want our friends to see that we're struggling in some way. And at this time, we still may not fully understand that it's dementia. It may be, starting to be more problematic, and we just start withdrawing and maybe getting depressed and not wanting to be out and about. But you might find changes in speech. You might find people who have difficulty finding words, maybe inserting a word that doesn't quite fit into that sentence and doesn't quite make sense, or sometimes stringing together a bunch of words that just don't even make sense at all. So these are what you might start seeing along the way. And sometimes that's when people start getting really frustrated because they realize that they're not able to communicate what they're thinking. They can't get it out, and it makes it very difficult for communication.
A couple of things that functionally that we see early on that are signs that things are progressing are someone can no longer manage their medications. We see that as a pharmacist, that they're forgetting to take medicines or maybe doubling up, just find it difficult to manage all of that. And same with the finances. We might get into that a little bit more later, but those can sometimes be signs that we can't really ignore this anymore and at least need to step in to provide some more help.
Right, and that's exactly where we start worrying about people's safety, whether it is managing their medications, so they're taking them as prescribed, Maybe it is not getting scammed. It's amazing. People come out of the woodwork when somebody starts having cognitive issues. You know, we get the handyman that shows up unannounced and wants to charge you for something that they did 2 weeks ago, and they come back and they charge you again and they charge you again. So we've got to be really careful and really aware that there's some safety measures in place. This may be where we also start worrying about driving and whether that's safe to do or not. Maybe this is where people start forgetting that they turned on the tea kettle, and then they go answer the phone and go on do things throughout the house, forgetting that they had put it on. So you get distracted, hard to focus, difficulty concentrating, and difficulty retaining things that are in our recent history. Short-term memory, the most recent stuff, tends to go first. Long-term memory sticks around longer. So I have families that say, well, gosh, mom can tell me every single detail of her graduation from high school at age 18. She can't possibly have dementia. But what happens, those memories are more intact. The memories that more recently, what I had for breakfast, who I saw yesterday, where I went. So those are the kinds of things that we start worrying about. And then as things progress to the late stage, that is where memory can be seriously compromised. And that's where we really worry about the safety issues. We want to make sure that there's a system in place for meals and medications and getting to the doctor's appointment, putting that structure around them, because a lot of times that's when they start losing the sense of day and night. They may be sleeping a lot during the day, so then they're up at night wandering. We worry about them leaving the house at night. We worry about them trying to find their way home. And a lot of times home is not their home where they live. It's the home of many years ago that they're missing. So they may start not recognizing where they are, that they actually are home, because it's a more recent home that they're not remembering. It could be a daughter coming in and she doesn't recognize them, or it could be somebody familiar to them, but it starts getting scary because they're not recognizing these people. Maybe it's more of a, they start worrying about strangers coming into the house, and it really are people that are known to them, but they don't look like they did 20 years ago when they remembered them. So sometimes it gets a little bit tricky.
Along those lines, if someone resembles someone at that age from a generation or two back, that can be confusing, because it looks like the person with dementia, their grandchild may look like their dad, and they remember their dad at about that age, and so it gets very confusing. This grandchild almost needs to be prepared that the person with dementia might mistake who they are and interact with them as if they're someone from a generation in the past.
Yeah. And again, the communication difficulties show up in the late stage, but may be progressing. So it may not be much verbal communication at all. And that's really when it gets important to think about your body language, your tone of voice, your, a smile on your face, and a gentle, calm demeanor. Those become even more important because they're not processing things like you and I would, and they're picking up their cues from those nonverbal aspects of our communication.
That's a good point.
Yeah.
But I'm just saying, and tasks need to be broken down into the simplest, one step at a time. Kind of, I think you're going to talk more about that later, but complex things, even like get dressed, may have to be broken down into find your underwear, put on your underwear, and just go step by step, rather than expect someone to remember all of the tasks, even though these are things that they've done for a very long time.
Right, and that's where we see people needing assistance with their activities of daily living a little bit more hands-on help. Reminders and cues are really important, especially when it comes to personal care and hygiene, incontinence, bathing. Things take a lot longer because you do have to break it down in small steps so it's not so overwhelming, and give those cues we'd like to have people be able to participate in their own self-care as much as possible. So you got to allow extra time, and it may be help, needing to cue that socks go on before shoes. But instead of putting all the socks and all the shoes there, maybe socks first. Let's lift up your right foot, let's lift up your left foot. So step by step, like Michelle was saying. Then when we get to the really late stages, that's when we start worrying about needing to start thinking about end-of-life care. We see people losing weight, sometimes swallowing becomes difficult. So then we worry about aspiration and pneumonia. We worry about them, breathing in their food and then getting lodged, where, we start seeing infections. And it may be like aspirations. It may also be just not, the hygiene is not where it should be. Because physical care can become very demanding. Probably not taking daily showers at this point. You're probably really, hoping to get a shower or two a week, or maybe it's a sponge bath only and not the full shower. So that's where we start seeing urinary tract infections, and the immune system can become compromised, and they just become much more vulnerable to infections, which when, by the way, there is an infection, that is when dementia signs and behaviors can become even more magnified. So we want to make sure that if we see a dramatic change in behavior from one day to the next, may want to check with the primary care physician, because it may mean that there's also something medically based going on.
This is probably a really good time to stop and ask if this is helpful, if there are questions about the stages, or how to manage certain stages, just kind of whatever you're thinking at this point, because we do want this to be especially helpful to you as caregivers.
Thanks, Michelle. I have unmuted everybody, so if you have some thoughts or comments, please feel free to share those at this time, either through your microphone or if you'd like to put it in the chat or questions panel. So we have one gentleman that says there is a massive amount of information and details to be understood.
Very true. And Ellen talked about this. Having walked the journey of dementia with one person may look dramatically different than the journey of dementia for another person. So there is so much to learn, and even the lessons you learn one time, you might feel like strategies that worked have to be relearned in different ways for someone else. I consider it one of the most cruel conditions that is out there, because it is so devastating on the person that's walking it. And right now we can't yet stop it, but it's so hard on everyone around them as well.
Yeah. And what we just went through so far today was really a recap of the last time. So I know Jeff has recordings of past webinars that will take a little more time on this information. I know we threw a lot out there already, and it was more of a review of an hour. So we kind of compressed it. It is a lot of information, but it might help to review that if you're interested in getting a little more detail and taking some more time with the information.
Also, a couple other brief comments. Support groups must be hugely important. Yes. And then another, I guess it looks like a question here. In early stages with early diagnosis, is denial common? For example, saying I was never good at remembering. And also, we've got some more questions coming in. So if you can maybe address that first question, please.
Mm-hmm. We see that a lot. It's really hard to admit that there are changes and that I'm struggling with something. So people are really good at compensating for their difficulties. When it's something they could always do, it's easier to make an excuse or to kind of cover it up. than it is to actually address it or admit it. So some people do show denial, and we do see people say, oh, I was never good at that, or no, I'd rather not do that, I'm tired, because they don't want to be put to the test. And so it does become difficult, and that especially becomes difficult when we're talking about driving and doing those things, that's their big sign of independence, and to have that taken away is really devastating to some people. I have clients who are very verbally intact, but very progressed with dementia, and being verbally intact and able to communicate and talk, and they're really good at covering it up. So they can schmooze over their physicians because they have these conversations and use really big words, and they make lots of sense. So it takes a skilled clinician who's able to ask some key questions and start noticing that maybe they're saying this wonderful information, but then they start repeating it over and over and over and over, which shows that they don't quite have the context of it. So it's we do see that quite a bit. Michelle, do you see that?
Oh, absolutely. Another element of it is there's this, I think it's one of the hardest phases. It was when the person with dementia recognizes that things aren't quite right, but they don't have the capacity to fix it. And so an example is someone recently, the two daughters and the person with the earlier stage dementia, they were sitting with the provider, and the provider was asking questions, and the two daughters were describing the things that they were seeing, how mom was getting confused and having trouble operating the microwave and having trouble doing things that had been easy just a couple months earlier. And the mother was getting so upset that her daughters would air the family business to this doctor and make it sound worse than it was, because she was sure it wasn't really that bad. And it's such a tense part of the progression when everyone can see it, but the person with dementia is just really grappling with, why can't I fix this, and why can't I do it like I did before?
And I'd like to mention, as somebody had mentioned earlier about support groups, there are early stage support groups. So there are support groups for family members to deal with it, but there are also support groups for people who are newly diagnosed. So they're there with peers, it's facilitated, somebody who's very knowledgeable of dementia, and somebody who has lots of resources and information that they can share, so that people kind of start understanding it a little bit better and knowing what to expect. Because it can be quite scary to get that diagnosis.
Oh, yeah.
If people are interested in looking into support groups, you can go to the website of the Alzheimer's Association, alz.org, and you can look at the listings of websites or support groups that they have throughout the state of Maryland. They also have a virtual one, so if as a caregiver you're not able to get out, you can do it virtually from home.
Okay, great, thank you. Do have a couple more questions here. I know we've got a lot to cover, but definitely want to get to these questions too. They're very good ones. When does one know when to employ additional physical help in a home?
A lot of times it really is due to safety and ability to function. So number one, we want people to be safe. If they're leaving the stove on, if they're walking out of the house daytime or nighttime, and we start worrying about whether or not they're going to be safe, that's a big red flag. The other one is, are they functioning? Can they fix themselves a lunch? Are they able to use the microwave? Can they manage their calendar? Can they drive? It's those kinds of things that really start being the important things. When they're not able to manage their finances, they start, they're just not taking care of themselves. Their hygiene goes down. It's difficult for them to get out to the grocery store, and their refrigerator is full with food that's spoiled. So we kind of look at the whole picture. Are they functioning well? And number one, are they safe?
Those are good. And a couple, I'm thinking of specific instances, families, what they've gone through. Sometimes a person will walk away and say that they're trying to go home or wherever and get lost and not be able to how to come back, know how to get back to the house. And they might have been clear as a bell that morning. It would never have happened. And then at some point they got a little confused in the afternoon and wandered away. Or sometimes people will go to the grocery store in their car and not remember how to get home, even if it's just a couple of blocks. And so, like Ellen said, often there will be a trigger moment where you realize things aren't quite as controlled as we thought they were, and it's time to step in.
Okay, thank you. Next question. My grandma is 86 and at late stage. Home caregiver has to bathe 3 times a week and she still eats and loses weight. At what stage should you consider a nursing facility?
So nursing facility can offer 24-hour care, and they're going to be able to give supervision if that person who needs the supervision, if family's not able to provide 24/7 supervision, that may be an option. Bringing caregivers in is also an option. So some people, many people are able to stay at home until death with dementia. If you have the right coverage, the right supervision, this instance, it may be a time where you want to talk to the primary care physician about instituting hospice. And that's an added layer of care, focusing on comfort care for that individual to be able to stay at home and not have to go to a facility and not have to go to the hospital. Losing weight is a big sign that hospice uses to be able to take people under the hospice wing. And the physician would write orders, and it usually is if they expect that person to live less than 6 months. Those are usually the triggering factors to be able to go on hospice. A lot of people get very concerned about hospice, thinking that they're the ones that are creating this end of life, and it really is not. It gives this added layer of comfort and support that you don't otherwise have, and it allows them often to stay at home.
Hospice provides something beautiful too, and then they get to know the family, the caregivers, and they give such a peace of mind of explaining what might happen next and when and how to handle those things. Lots of education. And remarkably, I would say, Ellen, tell me what you think, but it seems in the last 5 years or so, I've seen a number of people actually get better and healthier under hospice care, partly because everybody is just a little more coordinated and knows what to do. And it's just, like you said, that added level of care actually sometimes helps the person feel better for longer.
Yeah, can improve the quality of life for sure. And we have what we call a hospice honeymoon. As soon as those hospice services come in and start caring for that person, makes it a lot easier, and it looks as though they improve. But you're right, Michelle, some people do improve to the point where they're not able to justify them staying on hospice because they've improved and are to the point where they no longer qualify under Medicare standards for hospice. So they graduate.
Interesting. Okay. So I know we have a lot to cover here. We do have a couple more questions. Do you want to answer a couple more or move forward with some more slides?
Let's go through the medications and then get back into questions, because I know that's going to bring up some more.
Yeah, sounds good. Thank you.
So, should a prescription be written when someone is diagnosed with Alzheimer's? I will tell you that is a complicated question. It is not a definite that diagnosis equals prescription. So I'm going to try to break this down, but I do think it will lead to a lot of questions. So be writing those or thinking of those, because I want us to have a chance to talk through them. So the types of medicines that are available: the acetylcholinesterase inhibitors, there's your $5 million word for the day. Those medications, when you think about the impact they're going to have, think wet. So by inhibiting acetylcholinesterase, people who take these medicines tend to feel nausea, vomiting, diarrhea, especially on the GI side. They might have drooling or watery eyes. It's just the nature of what those medications do. They unfortunately do not cure Alzheimer's. For many people, they don't do anything that's noticeable. The benefit they can provide, and this is so hard to measure, is they might slow down the progression. Now, Ellen mentioned earlier, and it's been beautiful the way she has stated it, some people will get this diagnosis and rapidly progress through those stages that we talked about. Some people will get the diagnosis and progress over a decade or more very slowly. And so there are so many things to think about when deciding if one of these acetylcholinesterase inhibitors is the right approach. One is, are they at a stage right now that you would want to prolong? You know, if someone has progressed to the point where they don't know their spouse any longer, they don't know their children, it's hard to make quality of life decisions for other people. I understand that. But you've got to wonder, are we at a stage that we want to prolong at this point, knowing that we cannot stop it? If anything, we might slow it down a bit. I know, I'll use an example. I know of a situation where the caregiver was so worn out that prolonging it wouldn't necessarily have been a good thing, because we probably would have lost them both, because the caregiver just couldn't keep up with the demands of having the spouse with the dementia and the going through those stages of decline. So the first question is, the best you can do is slow it down. Are you at a stage where you want to slow it down? Does that make sense for everyone involved? The other thing, and this is difficult, we know that even if it slows it down, so the person does choose to start one of these medications, the donepezil or Aricept is the one that's used kind of by far the most commonly. So the medication is started, the person is on it for 2 or 3 or however many years, and then they have continued to decline, and the time comes when you're wondering, should we even keep this medication going? We've got enough data now to know that when that medication is stopped, there's almost always a rapid decline. The question is, does that rapid decline take that person to where they would have been if we had never started the medicine? Or does it actually take them even a little bit worse than that? There's no ethical way to really study that. And so it's a question to think about up front before starting the medicine. Are we committed to staying on it? Or do we realize that if and when we stop it, there could be a rapid decline? A scenario that I've seen too many times is when the family involved in this person's care is not all on the same page. And so one part of the family, maybe the person with dementia themselves decides, yes, I want to start this medicine. And so they start it and they're on it, but they start having these wet side effects. So they're maybe losing weight partly because they're experiencing the nausea or the diarrhea. And so they've been on it for a while. Another family member comes in, looks at the situation and removes the medication, maybe without telling everyone, and then the sharp decline occurs. I've seen that several occasions. And so it's not an easy decision of whether to start the medicine. And if it is started, make sure everybody involved is engaged and thinking along the same lines and in sync in the care of that person. Again, I know I'm probably stimulating a lot of questions, but let me go through the other ones and then we'll kind of think this through. So then the other option that's more for moderate to late stage is an anti-glutaminergic medicine. Again, another one of those big words, but it's memantine, or the brand name is Namenda. About the only benefit that you can really see with that that's measurable, because again, at this person, at this point, that person is that moderate to late stage anyway, so a lot of function has greatly declined, is in some cases it's been shown to keep people from needing nursing home level care. I got to be honest, as a clinician and having seen hundreds, if not thousands of people walk this journey, I'm not convinced there's really any benefit to Namenda. I'm not sure there's any benefit even to the acetylcholinesterase inhibitors. Now, the new medicine that's been in the news and gotten a lot of publicity over the last almost year is the anti-amyloid monoclonal antibody. So we know that these plaques form in the brain and cause brain function and structure to change and not be as effective over the course of Alzheimer's disease. This new medicine, as with all of them, are a step forward in better understanding the process of Alzheimer's disease. This aducanumab, this Aduhelm medication, will probably have its greatest benefit when we can identify people earlier than we can currently identify them in the Alzheimer's progression. Right now, we're not really able to identify that someone has Alzheimer's until they reach that point that we were just talking about, where there are noticeable changes. They're not functioning in the way that they did before. They've lost certain faculties and abilities to do things. But at that point, their brain has already undergone probably years of changes, long before it was obvious to the rest of us that something has changed. And so this Aduhelm medicine it's hard to show that it does much when it started after all of those years of damage have already occurred. But it's a huge promise for the future. And I was speaking to somebody just a couple of weeks ago who's actively involved in these studies. There are other medications similar to the Aduhelm being studied right now, and they're trying to use genetic markers and other indicators to identify people who might have Alzheimer's way earlier than we've ever identified it before, and give them these medications that diminish that destruction to the brain, in hopes that it will either buy people a lot more time before they have notable changes in their function, or maybe ideally stop Alzheimer's in its tracks. We don't have that data yet. It's just the promise or the hope that comes from some of these newer discoveries that are able to reduce the formation of some of these plaques. So that's a whole lot of deep science. I would love to hear your questions and see if I can explain it better based on where your questions are.
So if anybody has any comments they'd like to share, the floor is open and you're free to comment. I'm sure we have some questions about this in the questions panel, which I will get to as well.
And while we wait, Jeff, we could answer those other questions if you want.
Yes, absolutely. You're reading my mind there, Michelle. One question we have is dementia hereditary? My great-grandma had it, and now my grandma and her brother, but my mom didn't get it before she passed. My aunt's still living and hasn't caught it, so concerned if it's hereditary.
My understanding of that is that we are learning that there are some genetic markers, which means that there is a hereditary component, but there's more to it, and that's what needs to be discovered, is what is the more to it, because for some people It seems almost like a switch, like a light switch. For some people, something happens that switches it on, and that Alzheimer's process starts. And for other people that have the very same genetic markers, it's like the switch is never switched on, and they live out their life like your mother, never having any indications. And so there's so much research in trying to identify what do the genes mean, because it's not like if you have the genetic marker that you definitely are going to have dementia. It's not that
Michelle? Michelle?
at all. What
Okay.
else happens in our lives? Is it the environment? Is it our stress levels? Is it what? Yeah.
Seems like we just lost your audio there for about 7 or 8 seconds. So you're back now. Nope. Michelle,
Okay.
seems like you're back.
Where was I when it went out? Uh-oh, I don't know what's happening. If you can't hear me, Ellen, you want to do the rest?
Sure, we can go to the next. Seems there's a delay in your audio.
Okay.
So what we
Weird.
see
Okay.
as people progress through the middle, late, and end of life stages, that's where we see a lot of the behaviors. So people may be emotionally labile, meaning quick or dramatic shifts emotionally. They may be happy 1 minute and angry the next, and it shifts very quickly. And sometimes it could just be a quick event that just, like Michelle said, flips a switch and suddenly they're, a different person. Their mood is very different. Delusions or false ideas about something. That's when we see, the newspaper delivery guy becomes a guy who's stalking her or something like that. So you see like these unusual thoughts or inappropriate thoughts about what's going on around them. It's misinterpreted. Delirium, hallucinations, again, you're seeing, hearing, tasting things that aren't there. Sundowning often happens when people are in the later stages, where late in the afternoon, early evening, you might see a spike in agitation. You might see ruminating on something. You may see wringing of the hands or pacing the floor, or somebody who just can't sit. They're really, really upset and agitated, and they're very restless. And that often happens with people with dementia. And a lot of times they're just tired. They've had a full day. Their fuse is very short, and things will set them off quickly. And they start wanting to go home. They know that it's the evening. They start worrying. And what we want to do as caregivers is bring that anxiety down. And that's being reassuring. That's maybe distracting them to an activity. Maybe it's making sure that the TV is not blaring and we have 10 people visiting and there's a lot of hubbub and chaos going on. We want to kind of just get the, softer lighting, maybe some music, things that will distract, and we want to kind of bring down that agitation and aggression. The depression is something that we need to watch for. Sometimes depression even masks dementia. So the dementia looks so much worse than it actually is because it's undiagnosed depression. So working with your primary care physician early on is really important to rule out those underlying medical events, because sometimes we think it's dementia and it could be a vitamin deficiency. It could be polypharmacy. It's the interaction that you're seeing between medications. It could be undiagnosed or untreated depression. It could be a thyroid issue. So we really want to make sure that we've ruled out the medical basis before we start giving a diagnosis of dementia. Other things, behaviors that we see is wandering, somebody wanting to go home, or that sleep disturbance, which we talked about, where the days and nights might start shifting, or they're nodding off during the day so they're not tired at night and they're just, anxiously walking around the house or trying to go outside. Michelle, you want to try now?
I'll try again. Can you hear me? Antipsychotic medications are sometimes used for these behaviors. Now, there is a warning that's on these medications that people that use these medications when they have dementia have a higher rate of dying. The question is, were they further down the path and more likely to have a shorter lifespan anyway, because their behaviors were the indicator of that? Or was it the medication that actually hastened their death? And again, we don't have a clear answer on that. So they're only used when the person is at really risk of hurting themselves or others. And we do not use benzodiazepines because they will just make the person even more confused and not help the situation. So that's medicines like alprazolam or Xanax or Valium or clonazepam. Those should not be used in anybody with any level of dementia. And then not over-the-counter sleep medicines, because again, those are very drawing. So the opposite from the effect of the medicines we use to try to help with Alzheimer's. And they are very, very confusing. They lead to falls and they don't help anything. And so behavioral management is through our behaviors and the calming environment as much as possible. But when we have to use something, then it's typically antipsychotics at the teeniest, tiniest possible dose.
So when it comes to communicating with somebody with dementia, it can be really difficult to figure out what's going to work. Sometimes we have to just trial and error, try a couple of things, and maybe it'll work after a couple of tries. Maybe we need to just let it sit for 5 and 10 minutes and then come back and retry. Maybe it's working out a strategy. If anybody has children, you figure out a way to manage their behavior, and as soon as you think you've figured out the magic potion, something changes and you've got to figure out something else. So it's very similar in that way, where we think we have a way to communicate with them or get them to cooperate with getting something done. But when you figure that out, then something changes. So we have to be flexible. We have to have a sense of humor. We have to try to connect with them in ways that they have moments of joy. We need to use their strengths and help them. So if they're physically, they're really good, maybe having them help with folding towels and doing things like that. You know, just find ways to incorporate them into the daily life, because just like all of us, they want a purpose too. So we need to maybe find a purpose for them that's something that they can do within their remaining abilities. So again, body language, your attitude, your feelings, the way the expression on your face, and touch becomes much more important at this point, because they may not understand the instructions that you're giving, even if you have simplified them. So it may be reaching out your hand and holding their hand and helping them along and showing them where you want them to go. Maybe it's helping them pick out their clothes, but giving them a couple of options, holding up 2 shirts instead of opening the closet and showing them a whole slew of shirts to pick from, because that can be very overwhelming. So we want to simplify, make it easier. Maybe they're just going to point to a shirt as opposed to tell you, I want the red blouse. But just finding ways to communicate in a calm manner that's going to keep them engaged with you. So it's really important that you even get the person's attention. So I think I read the other day that the average person has about a 7-second span of attention. So if you're watching TV, and I've done this, the picture is changing at least every 7 seconds, because otherwise they're going to lose our attention. So if that's the average person, think about a person who doesn't have dementia. You don't have a big window to get their attention and get your message across. So that's why we really want to simplify. Instead of saying, let's go upstairs and take a shower, bring your slippers with you, let's go. You want to just say, shower time, and grab their hand and motion upstairs. Sometimes that's the way to do it. So you might need to get at their level, might need to make sure you're making eye contact. It may be that touch. What you want to do is make sure you have their focused attention, but you need to use it efficiently, because you may not have a long attention span. So using those nonverbal cues, smiling and kind of encouraging them, simple words and sentences, speaking slowly, calmly. You may need to rephrase what you said. They may not understand the way you said it, but you might need to rephrase it and it'll make it more sense to them. Again, we don't want agitation and gestures that show that you're irritated. It's being calm, and sometimes that's very hard to do. That's why it's really hard to have backup. You need respite, you need to do self-care, and you need to make sure you have other people who can step in when you as the caregiver need a break. It's really important to get that break so that when you do come back, you're rejuvenated, you're refreshed, and you feel like you can do this. Coming back again, like I said, 5 or 10 minutes later to try it again if it's not working that first time. Having somebody else try it. Sometimes they tend to listen to one person more than another, or it may be just the way things are today. And so just having the ability to be a little bit flexible, allow extra time if you're getting somebody ready to go to a doctor's appointment, maybe start an hour or two ahead. Maybe make those appointments in the late afternoon or early afternoon when it's a better time for them than later in the day. So you've got to think about how they function and what their daily routine is like, and try to stay in that routine as much as possible. Giving two answers, is it this or is it this, is much better than saying, which one do you want? And I also caution people against using yes or no questions. Do you want to do this? Usually the answer is going to be no, no matter what. So you may not want to ask a yes or no question, but you're going to find out what works. It's trial and error, and it's just attempting something different.
Something that you had on a previous slide, Ellen, about state the name of the person rather than sometimes in conversation we switch over to her or she or he, but keep saying the name for that same reason of maintaining attention, keeping them focused on who you're talking about.
Yeah, absolutely. Absolutely. So when we listen to somebody with dementia, sometimes we have to be patient to get that answer or allow them extra time to come up with that word. It's okay if they're struggling for an answer to maybe suggest a word or point to something, but we don't want to be finishing every sentence for them because that gets very agitating. Imagine how you feel if somebody was constantly coming behind you and finishing your sentences. So we need to think, like, how would I feel if I were in this situation? So they may be struggling for an answer. Maybe you need, sometimes it's even pantomime. Sometimes it's even picking up something. You mean the phone? Or you mean whatever it is. You may need to give them some cues so that they can come up with the word. And watch for their nonverbal cues and their body language. Do you see that they're getting agitated? Are they escalating? And we need to like calm things down before we can move forward. Otherwise, it's going to continue to escalate. So it's really important to try to understand what they're saying and that they know that you're trying. Encourage them to be involved as much as possible. If you're fixing dinner, have them with you. Maybe they could stir something for you. Maybe they could roll up the forks, knives, and spoons in a napkin and put them around the place settings. There's lots of things that people can still do. And if the forks and the knives and the spoons aren't exactly in the right place, it's okay. They feel like they participated. They feel like they were able to contribute. So that's what's really important, again, is that purpose. You may need to show them, set up the first table setting, and then they can copy it. Sometimes they just need that first step, like when they're brushing their teeth. You might need to put the toothbrush in their hand and hand over hand show them how to do it, and then they can continue because the muscle memory kicks in. So it's really important to find ways to give them strategies to still be successful in the things that they can do.
I've been in homes where all the steps to run the microwave are posted on the microwave. All the steps to brush your teeth are on the mirror by your toothbrush. Just little prompts and helpful things along the way.
Yep, and when things get tough, when you're finding somebody who's not overly cooperative, or they're saying, I want to go home, I want to go home, I want to go home, This is really important when we're able to distract them. So find an activity that they enjoy doing. Maybe it's a puzzle, maybe it's listening to music, maybe it's singing a hymn that they used to sing years ago that is their favorite. So finding something that resonates with them. Pulling out the old family album so they can reminisce and see memories of things that their brain is more connected to. That tends to calm people a lot more. So you might have to distract them with some other activity, redirect them, or validate them. So when you have somebody who is asking where their husband is, but we know that their husband passed 6 years ago, and they're not remembering that they passed. Sometimes you don't want to relive the grief because they're going to go through the grieving stages all over again if you tell them. So the important thing is validating. Yeah, you miss him. What was your favorite thing about him? What did what was what are the things you love to do? And they start reminiscing and again connecting with those memories that are happier instead of insisting that they know that person has passed, because it really is about quality of life at this point.
Yeah.
So again, affection, reassurance, rubbing their shoulder, letting them know that you're there for them, because it's a really scary road to go down by yourself. So if they have reassurance that you're going to help them when they get confused, that's really important. And then, like I had mentioned earlier about remembering the good old days, is just reminiscing with things that are important. Some people make shadow boxes. Some people pull out old movies or old photo albums, maybe a journal. I have a client that has a stack of greeting cards that were sent to them over the years. And we'll sit and we'll read the greeting cards, and it's as if it just arrived in their mailbox. So it's really great just to give them, come up with excuses and ways for them to talk about the good old days. But as a family member, you may get some nuggets or some gems that are these stories that are part of family history that you never knew about.
It's a good point.
So I think we talked about this, getting their full attention, making sure that they can see you, you're making eye contact, and minimizing those competing noises. So maybe if we're having a gathering, it's a smaller gathering than usual, or it's at a better time of day where they can handle the hubbub going on around them. Maybe it's when we're having a conversation, we don't have the TV blaring in the background. It's just finding ways to simplify not only our communication and what we're talking about, but also the environment around us. Maybe dimming the lights, maybe having some soothing music. Maybe it's not having a lot of things going on at once, because it can be very distracting and unsettling.
This is such a deep topic, and again, our time has run away from us. We want to remind you that Ellen and I have put together a program called Propel, Powerful Retirement Options for Your Purpose-Filled, Engaged Life. If you are someone who's nearing retirement, we would love to tell you more about this, because planning health, we're not talking about planning end of life, we're talking about planning health and fulfillment and engagement is something that doesn't often happen by chance. So we've designed this for you. And with Jeff, with any minutes we have left, we would love to answer any other questions. I know, again, time went so fast.
Time did go fast, Michelle and Ellen. And I mean, you've given so many best practices that are just extremely helpful for caregivers that are, going through what can be very challenging situations for their loved ones. And so I just want to thank you for your expertise again. Just really appreciate your time and know it's very valuable, and just want to thank you. Very helpful for everybody. Also, I've gone through the Propel modules. They are extremely helpful. I would encourage everybody to check it out. And Michelle, there's the Propel Your Wellness website there. Is there anything that people need to do to sign up or get a link to get started?
Check it out. If you're interested, let me know. As a client of Elville or a friend of Elville, I would love to give you a code so you can try it at a much reduced price. So
Okay.
check it out, and if you're interested, I will pass that on to you.
Okay, thanks. We do have a few questions. I know we're at 2:30. I know people have to go. That's understandable, but we'll try to power through some of these questions here. So thank you for the questions. So let's see, how important is it to have a doctor differentiate the problem? Our neurologists use the term senility. How do we find out if it is Alzheimer's?
Just from the standpoint of selecting therapy options, it can be helpful to try to differentiate what is the underlying cause. And I think the biggest reason is, as Ellen indicated, there are so many treatable things that can look like dementia that you want to rule out all of those, the thyroid, the vitamin levels, the hint of depression, all of those things before. I would say senility is not a thing. You can live to 120 and never have cognitive decline. And so it's not like it just goes with aging. There is an underlying pathology, and the better we understand it, the better we know how to treat it.
And just to add to what Michelle was saying is that it often is a series of evaluations. So it may be a cognitive screening or a more in-depth neurocognitive assessment. It could be blood work, it could be brain imaging. So there's a lot of things that they do to kind of go down that checklist to be able to gather enough information to make a more definitive diagnosis.
Okay, next question is, when should one stop driving?
If only we knew.
Safety is an issue. We want to make sure that not only the person driving is safe, but everybody out on the road is safe. So what often leads up to thinking that you need to is when you start seeing dents in the car that weren't there before, or near misses or tickets. You start seeing that kind of thing. People getting lost in areas that they drive all the time, or people starting to wander in their car and they end up, you hear the stories about people ending up in Ohio because they just got on the road and kept going and didn't know how to get off. So, you know, we don't want that. So you preferably stop that before it gets to that point, and it could be a reevaluation through the MVA. They can do driving testing to see if somebody is safe. It can also be done with an occupational therapy clinic that assesses driving ability. And it can also be a conversation with your primary care physician. But as caregivers, if we know the doctor is saying they shouldn't drive, we can also be liable as caregivers if we continue to give them the keys. So we want to make sure that everybody's safe.
Okay. What are the best advocate techniques when hospice denies care?
I guess it depends on their reasoning for, you know, the two of the big things are if the physician thinks there's only 6 months or less to live, and if there are a lot of chronic health conditions and a continuation of losing weight. It can be something to talk to the physician, and maybe the physician can be a liaison. Care managers advocate with the staff, with the people who are doing evaluations. In hospice, we may have some clinical knowledge that they didn't get during that transition that we could help share with them, that they might actually qualify then under Medicare standards.
Okay. Going back to medication, how do we convince someone to take medication when they are not even demonstrating symptoms or have not been diagnosed?
Oh, that's a great question. And they probably shouldn't be taking, just to clarify, if we're talking about those Alzheimer's related medications, those shouldn't be prescribed until a more accurate diagnosis is made. If you're thinking about other medications, that can be tricky because for whatever reason, either the person forgets to take them, finds swallowing difficult or uncomfortable. They may not be taking the regular, like the blood pressure medicine and the diabetes medicine, as regularly as they did before. I'll put in a plug for the pharmacist at that point. If it's a situation where swallowing is getting difficult for some reason, or the person finds it uncomfortable, we can often find other dosage forms, other ways to use those medications if that is the issue. But the big thing is to figure out why they're not taking or not wanting to take those medicines.
Yeah, and I can add that I had an experience recently where somebody was taking fluid pills, and they were giving it to them at night.
Oh,
Well, they were up all night going to the bathroom. And so of course they didn't want to take it, but they really needed to have that medication on board. So it was a simple conversation with the primary care physician to suggest them taking it earlier in the day.
Okay, thank you. A few more here, and thanks for answering these, and thanks for the questions. After an MRI of my head, quote, mild degree of central cerebral atrophy, unquote, was found. Is this a hint of dementia?
boy, it could be a number of things. And so I wouldn't jump to the conclusion of dementia, but rather, and I know it's probably not the answer that you want, but working with the healthcare team to see what else is happening, because those sorts of changes don't usually necessarily happen all by themselves. So kind of get into the heart of what is underlying it all.
Okay. Next question is dementia diagnosed after a fall treated differently or require additional testing / analysis? And in parentheses, there is dementia in the family, but after a fall with a bump to the head, a 65-year-old was diagnosed with dementia.
Oh, that brings up a topic that could be 3 sessions. That when something sudden happens like that, and there could be a concussion causing that person to not think clearly. Sometimes after a surgery or a traumatic event, there's something we call delirium, where the person is temporarily very confused. And I've seen too many instances where that gets misunderstood as dementia, and it is not. And so I would hesitate to rely on a diagnosis that's made right after a head injury. Wait until any concussion, delirium type symptoms could resolve, and then figure out where their cognitive thinking process really is.
Right. Dementia rarely comes on suddenly. It's just not how it progresses. It comes on very gradually. So we had mentioned earlier on that when there's a big change, a dramatic change very suddenly, it usually has an underlying medical event.
Okay. So we have a number of people that have shared their appreciation to you for your time and sharing the information. One person says, phenomenal, I've learned so much more, and I'm sure my mom will be happy I learned it. Thank you for the information. So again, thanks to all the questions, Ellen and Michelle, thank you for your time. So as far as my follow-up, there's a couple of questions about that. I will send out both of the presentations, parts 1 and 2. I'll send out both videos for you as well. And I'll have that out by tomorrow morning. As far as our wellness series goes, we are going to take a break in June, and then we will reconvene in July. So we hope that you can join us. We'll have a date out for you very soon for that. Check out our calendar of events. We have some great events coming up, including this Thursday, Medicaid long-term care asset protection. And then on the 27th, we have our estate planning and elder law essentials with Mr. Elville. And our client event is this Saturday, which we're very excited about. We've had a few cancellations, so if you're interested and want to come last minute, we've got a little bit of space, so reach out to me and we'll slide you in there. So that is it for today. Thanks for hanging in there with us. I know it's 2:40. Ellen and Michelle, thank you very much to all of our attendees. Thank you for making it a great webinar as always, and thanks for being part of the Elville webinar series. Have a great afternoon, everybody.
Thank you.
Thank you.